Dr. Carolyn Clancy, who I've now known for quite a number of years because she has been serving as the director of the Agency for Healthcare Quality and Research, which we often refer to as AHRQ, since 2003 through both the administrations of President Bush and President Obama. And Dr. Clancy also happens to be an internist and a health services research herself. And if Dr. Leaf is viewed as the father of the patient safety movement, I often think of Carolyn Clancy as the quality mom, the person who has tirelessly been working within the federal government to raise the visibility, the priority, the urgency of these quality and safety issues and really put them on the map. She's an extraordinarily well-respected leader by every stakeholder group in the healthcare world, and her work really touches on every aspect of healthcare. And she has the experience as a practicing doc from the ground up to the inner workings of the public policy apparatus. So, Carolyn, with that, I know you're going to tell us more about the Partnership for Patients initiative itself.
Great. Well, thank you, Deborah. First, I'm really thrilled by the work of the campaign and thrilled to be here and delighted to be thought of as the quality mom. So I'll definitely take that. Next slide, please. So the Affordable Care Act, I think you've probably all heard a lot about fixing broken health insurance rules and helping to cover millions of previously uninsured Americans, a national tragedy, and we're making a difference right now. That's all really good news. What a lot of people have not heard about is all the ways the new law is also reducing costs while improving the experience of being a patient, being a caregiver, and being a healthcare provider. So the Partnership for Patients, Better Care, Lower Costs, is one example of how the President is using provisions of the Affordable Care Act to make health care in America safer, more efficient, and less costly. Next. And I want to talk for a couple of minutes about what this means to real people. Because at the end of the day, I think that's certainly what moves healthcare professionals. It's what moves all of us, knowing that these statistics can be alarming, but when it's somebody you know, wow, it has a whole different impact. So the first person I want to talk to you about is Josie King. So you can see her picture here. She's really an adorable toddler, around 2 years old, I believe, who one night stumbled into a hot tub and got pretty badly burned. It was rushed to the hospital. I'm sure you can all imagine how frantic her family was. Her mom, Sorrel, is shown with her here. She went to Hopkins, and of course, a very, very terrifying experience for the entire family. But then she was sailing along, doing well, close to discharge, and her mom said, you know, she just doesn't look right. And the nurses said, no, not to worry. She's about ready to go home. And essentially, her mother's concerns were dismissed. And in fact, a few minutes later, they had to call what we call a code because her daughter had had a cardiac arrest and they were unable to bring her back. So here she is, poised to go home. They're imagining getting her toys and stuff ready. Finally, their anxiety and anxious journey is over, and instead she dies. Very, very tragic incident for the whole family. And ultimately, her mom became a very, very important consumer leader and advocate for safer care, reinvested part of her settlement from the hospital and the institution in a Center for Safety at Hopkins. I was just up there yesterday, and they're doing phenomenal work and bringing others with them. Next slide. Now, Patrick Clancy is my dad. So a little over a year ago, I got a call at a national quality meeting, interestingly enough, from my stepmother, who was crying so hard I actually couldn't understand her for a few minutes. And it turned out my father had been admitted to the hospital coughing up blood, quite a bit of blood. He was on a blood thinner at the time, and there had been a miscommunication about changing his dose. Now, changing the dose is a very common thing to do to make sure people are in the right range. And the nurse said to my stepmother, give him 2. And I think it probably seemed self-evident to her that she meant 2 milligrams. My stepmother thought she meant 2 pills, and he got way, way, way out of range. So he was admitted to the hospital, and a completely avoidable admission if communication had been more effective. And I'm sure if you think about it, it's not surprising that when something like this happens, everybody in healthcare feels horrifically guilty. So, of course, he had a lot of really expensive tests. Thankfully, after about 3 days, he was discharged home. He didn't experience another harm in the hospital. His medication back on track, but a very, very scary experience for everyone. That's really what we're talking about in terms of readmissions, trying to prevent that. Next. And as Dr. Lee pointed out, these stories are not rare, and Deborah made the same point as well. The numbers she gave you for infection is about 1 out of every 20 patients in American hospitals is affected by a hospital-associated infection. Among chronically ill adults, about a little over 1 in 5 report a serious error in their care. You heard the statistics about Medicare beneficiaries. And if you think about it as leading causes of death, medical harm is number 4 in terms of leading causes of death in the U.S. And the good news is, although we've seen really important successes in the recent decade, and Dr. Leap, I think, described those very clearly, we still have pretty substantial variations in the quality of care. So we can't be confident yet that no matter where you land for care, it's going to be reliably safe and high quality. And in the same way, if any of us getting on an airplane would like to know that the same kind of teamwork that we saw by Dr. Sullenberger, Captain Sullenberger, prevailed and nobody died. We'd like to think that about hospital care, and we know we can do much better, and we must. Next. So the focus of the Partnership for Patients is very direct. First is to keep patients from getting injured or sicker. The goal is by the end of 2013, preventable hospital-acquired conditions would decrease by 40% compared to 2010. Mind you, we think and we know from the experience of hospitals right now that a higher decrease than that is possible. But this is overall across the nation, and that would mean 1.8 million fewer injuries with more than 60,000 lives saved over the next 3 years. The second goal is to help patients heal without complication, and that by the end of 2013, preventable complications during a transition in care from one setting to another would be reduced by 20%. That is, hospital readmissions would be decreased by 20% compared to 2010. All told, this has the potential to save up to $35 billion over 3 years. I do just need to make a very brief comment that when we're making estimates about this, certainly from the government, we are by definition being very conservative, and my colleagues have had the lead on these numbers. So I'm going to tell you they're solid, and it's a low estimate. Next slide. So how does change happen? John Berwick is fond of saying that, safety didn't get safer on airplanes. We didn't do a better job because we just kept saying to pilots, please try to be safe. We actually put in place some proven strategies, teamwork, simulation, trying to anticipate the worst and knowing how we would react if we did. The same thing is happening in healthcare. We can and must apply many different types of incentives that are professional, because every single healthcare professional wants to do the best job possible, and incentives that essentially say, at a bare minimum, we're not going to pay more for extra care. And the real impact that is a result of harmful care, the real impact of that is that gets the green eye shade guys on board at hospitals so that they can make resources available, because they know in the long run they will save money and the country will save money and care will be more affordable. Doing this means we have to show successful alternatives, and we have to offer intensive supports. Getting to a place, providers want to work in teams. They want to have a culture of safety, and that's very, very different than how the vast majority were trained. So it's kind of learning new tricks, and at the same time, we know people can do that. Next slide. So at a national level, the vision is strong public leadership commitments. We want the boards of all partnership hospitals to publicly embrace the aims of the initiative and remove barriers to progress. I was very excited to be in Iowa just a couple of weeks ago. They became the first state where every hospital in that state has made a public commitment to this campaign. A second part is, as you're hearing from Dr. Leap and me, you can tell that some hospitals are further along in this journey than others. So we want to both raise the floor, that is to say, bring up hospitals that are relatively new to these ideas, at the same time saluting and applauding those on the leading edge to keep going and keep accelerating so that they can show us what's possible. And we have to put a very strong focus on smooth transitions between care settings. Those of you who have been discharged from the hospital yourself or have a friend or loved one will know it's often a fairly chaotic time. Stressful doesn't even begin to describe it, and we can do a much, much better job. Next. So what will be different about hospital care? Today, as Dr. Leap noted, almost every hospital has a patient safety program, and that's good news. But it's not completely clear, and probably not the case, that leadership regularly reviews the quality data. So what we'd like to see is that the boards of all hospitals understand that quality and safety are part of the bottom line and just as important as the financial information they've seen. Sometimes in response to our growing awareness about patient safety challenges, we've seen something of a hodgepodge of different programs, and as in any other aspect of life, that sometimes means the left hand doesn't know what the right hand is doing. And what we've seen from organizations that have been very successful is that they've got a portfolio of 10 to 12 improvement projects, areas where they've got a relentless focus on making care safe every time. Understandably, in the early phases, hospitals have been getting credit for participating, for setting up programs, for raising awareness, and that's a good thing, but as Dr. Leap and the studies he cited showed, sometimes things get better and sometimes actually they don't. And what we're going to be transitioning to is major incentives to change outcomes. Increased transparency so that all of you know about when a hospital is participating and what the results have been. To date, there has been limited work on readmissions and not a clear strategy for care transitions. We're still in the building awareness phase there, and what we know is that with dedicated staff and programming around seamless care transitions, we can do a much, much better job. And frankly, today, patients and families are not an active part of the process. Sometimes you feel a little bit like being a passenger on that plane. The one person who's in charge is not you. And what we expect and know can happen is that instead hospitals can interface with the patient and family movement supported by the partnership, and we consider the Campaign for Better Care to be one of the leading partners in that effort. Next. So how do we do this? This all sounds great, doesn't it? First, we want to build on tremendous enthusiasm from the private sector. Second, we want to work with our partners to support the hard work of changing care delivery to make care safer. The Secretary Sebelius, announced up to $500 million available in financial support just this morning. So the timing of this webinar couldn't be better. There will be national-level content, tools, approaches available for everyone, and supports for every facility to take part in cooperative learning. How, the specifics of how this gets done at every hospital, probably going to look a little bit different, just as they did in the state of Michigan. We had the privilege of supporting that work, and the great thing was it worked in intensive care units in huge academic medical centers, and also in very tiny hospitals. Obviously, how it was implemented in those very different institutions is going to be different, and we have a lot to learn from both. I mentioned that we want to make sure that the leading edge keeps moving so that we can all sort of run it as fast as we can to catch up to them. So there will be an advanced participants network for ambitious organizations to tackle all causes of harm. And very importantly, we have to have engagement from patients, families, and of course, healthcare professionals. Measurement and data is going to be part of this, but if there's one thing we learned from the state of Michigan, it's that collecting a small amount of data and giving people regular feedback on how they're doing can make a dramatic and sustainable difference. In addition to that, there's ongoing work with communities to improve transitions between care settings. Next slide. So this slide, very, very tiny font, just lists some of our partners. Over 1,800 hospitals have publicly pledged to be part of this partnership. All told, there are over 4,300 partners. So we're very, very excited that people are excited about this. Next. The very important message is this is not just fancy rhetoric. We're not asking people to defy the laws of gravity. We already know that this improvement at this scale is possible, achievable, and has been done. I've listed a few examples here. 150 New Jersey healthcare facilities have reduced pressure ulcers or bed sores by 70%. Rhode Island has reported a dramatic decrease in those same central line infections. Ascension Health Sites, a large health system in the Midwest, participating in a perinatal safety initiative, have achieved groundbreaking birth trauma rates at or near zero. So we know that this is possible, and there are institutions out there to learn from. Next slide. So our ask for you is to join this partnership and sign a pledge of commitment. I've listed the website here, and I know it will be available from the campaign as well. Next. So I have to say that talking about tools often sounds a little abstract. My family tells me this all the time. So I wanted to just tell you about a couple that come from very well done leading edge research. We know they're valid. The Project RED, the Re-Engineered Discharge, this is a project that is actually using a nurse and a pharmacist to help people with discharge from the hospital, and they were able to reduce the rates dramatically in the first 30 days after hospital discharge. Now, at a time when many hospitals are still suffering from financial strains, what the team is testing now are computer avatars. When I first heard about this, I was a little concerned. I imagined my father being plopped in front of a video and falling asleep. Then I saw the program. It's really terrific. It's interactive. And I'm told that in many institutions, patients actually like the avatar named Louise better than real-life nurses because she's always in a good mood. Nobody calls her. She's not interrupted. It all works great. And you heard about the central line infection. Next. We also have at ARC and will be and have been making available through the campaign information from patients and families. It makes a huge difference if you ask questions. Sorrel King has really made a dramatic difference. Many patients, as Deb Nesses reminds me a lot, and she's completely 1,000% right, the game changer in all of this has been activated consumers. Because I can tell you from the clinician side, they too want to make care safer, but you know, they're very, very careful people. And when a consumer says, why can't we go faster, suddenly we change from it's really important to be extremely careful and get it right to yes, we can do it right now. It's dramatic, exciting, and very, very important. So let me thank you for the opportunity to join you today.